In this video, we shall discuss tuberculosis, in particular pulmonary tuberculosis. TB is a common disease. It is estimated that 1.5 million people die every year of this disease. Unfortunately, more than 50% of these deaths take place in India. Extremes of age, malnutrition, overcrowding, and immunosuppression, for example, due to HIV infection, are important risk factors for the disease. It is caused by Mycobacterium tuberculosis. It is acquired by inhalation of aerosolized droplet particles from other patients. The bacilli get lodged in the alveoli. The body mounts an immune response, and these bacilli get surrounded by lymphocytes and macrophages. Some of these macrophages turn into epithelioid and Langerhans cells. These lymphocytes and macrophages, along with these specialized macrophages, together form a granuloma. Several granuloma together form what is known as the Ghon's complex. The infection usually travels to the hilar lymph nodes, where a similar reaction takes place. The Ghon's focus, along with the hilar lymph node, is known as the primary complex. In this X-ray, a primary complex is well delineated. The body usually mounts a good enough inflammatory response to form a fibrous capsule around the primary complex, which prevents further spread of the infection. The disease may remain latent for a long period of time, sometimes for the rest of the life. However, occasionally the immune response is not sufficient to contain the infection, and it may spread to become clinically evident. This is known as progressive primary tuberculosis. Tuberculosis that becomes clinically evident several years after the primary infection is known as post-primary tuberculosis. This may be due to reactivation of latent tuberculosis or because of a new infection. Disseminated TB is known as miliary TB. Pulmonary TB usually presents with cough, which may be dry to start with, but often becomes productive. The sputum may be mixed with blood. If large parts of the lungs are involved, the patient may also feel short of breath. Significant pleural effusion may be another reason for shortness of breath. The patient also usually has significant systemic symptoms like fever, which is usually low grade but may occasionally be high grade also. The fever is usually worse in the evening. Night sweats are common. Patients also often complain of malaise, loss of appetite, and weight loss. Clinical examination may be unremarkable, although some patients may look cachectic, and lymphadenopathy, especially cervical lymphadenopathy, may often be seen. Patients who are suspected to have pulmonary tuberculosis should undergo appropriate investigations. Imaging is an important part of the investigative process. Chest X-ray is the most commonly used method of imaging. CT scan is sometimes used when there is diagnostic dilemma. The X-ray usually shows infiltrates more often in the upper zones, sometimes progressing to collapse and consolidation. There may be evidence of cavitation and fibrosis, usually at the apices. Hilar lymphadenopathy may be seen. In some patients, there may be pleural effusion. Miliary tuberculosis is seen as miliary mottling on the chest X-ray. This is a chest X-ray showing infiltration in the right upper zone. This is another X-ray showing ill-defined opacities in the left upper zone with clearly evident cavities. There is also a solitary cavity on the right side, the right upper zone. This is an example of miliary mottling seen in miliary tuberculosis. Small nodules can be seen scattered all over the lung fields bilaterally. Examination of the sputum is important. Microscopy is usually done with Zn staining or with auramine staining. The sample should also be sent for culture. If the patient is not bringing up enough sputum, the sputum may be induced, for example, with the help of nebulized hypertonic saline. When the patient doesn't bring up any sputum at all, bronchoscopy may be done to obtain bronchoalveolar lavage, which may be subjected to similar tests. These days, we also have CB-NAT, which is based on nucleic acid amplification technology, which is more sensitive than microscopy in detecting Mycobacterium tuberculosis. If pleural effusion is present, fluid should be aspirated for analysis. The pleural fluid is usually exudative. There may be plenty of lymphocytes, and ATA level is usually elevated in the pleural fluid. Yield of acid-fast bacilli is very low in pleural fluid. Pleural biopsy is sometimes done, and if it detects non-caseating granulomas, that helps to establish the diagnosis. Tuberculin testing is often done in children. In adults, there is high rate of false positivity because of past infections and BCG vaccination. Once the diagnosis is established based on the clinical presentation, radiological findings, and examination of the sputum, it is important to give appropriate treatment. The first line drugs are isoniazid, rifampicin, pyrazinamide, ethambutol, and streptomycin. Streptomycin is given parenterally, usually intramuscularly. All the other 4 drugs are given as oral tablets. The standard regime in pulmonary tuberculosis is a 6 months course with an intensive phase in the first 2 months comprising isoniazid, rifampicin, pyrazinamide, and ethambutol. This is followed by 4 months of a continuation phase where isoniazid, rifampicin, and ethambutol are given. Pyrazinamide is not given in the continuation phase. The length of treatment, as I said, is 6 months for pulmonary tuberculosis. In the case of CNS infection, for example, in tubercular meningitis And in bone TB, the length of treatment is longer, for example, 1 year. The second line drugs are quinolones, ethionamide, caprimycin, kanamycin, amikacin, and macrolides. They are used in multi-drug resistant tuberculosis. As several drugs have to be administered and the duration of treatment is quite long, so compliance can be a problem. Patient education is therefore very important. If there is significant concern about compliance, directly observed treatment may be given where the drug is administered in the presence of a healthcare professional. Sometimes patients may need to be admitted to establish compliance. Poor compliance may be the cause of drug resistance. Multi-drug resistance refers to resistance to at least isoniazid and rifampicin. It is a growing problem. The length of treatment is much longer in MDR tuberculosis. The drugs are costlier with more serious side effects, and treatment failure is not uncommon. Even the first line drugs have significant side effects. Isoniazid, rifampicin, and pyrazinamide can all lead to derangement in liver function and sometimes frank hepatitis. Ethambutol can cause optic neuritis. Isoniazid is known to cause peripheral neuropathy. Pyridoxine is given along with antitubercular treatment to prevent peripheral neuropathy. If patients develop significant derangement of the liver function, all these hepatotoxic drugs, namely isoniazid, rifampicin, and pyrazinamide, should be withheld. The patient is usually given ethambutol along with streptomycin and a respiratory quinolone like levofloxacin. Once the liver function settles, these drugs may be reintroduced one by one. If the culprit drug is identified, it is stopped and the other drugs can be continued. If the patient tolerates both isoniazid and rifampicin, then pyrazinamide is usually withheld. These are some of the complications. Pleural effusion is quite common and may require aspiration or sometimes drainage. Otherwise, the treatment is similar to pulmonary tuberculosis. Meningitis is a serious complication. Apart from the systemic features, the patient may complain of headache, confusion, and may have neck rigidity. The diagnosis is confirmed by CSF analysis. Disseminated TB refers to widespread infection involving several organ systems. On the chest X-ray, usually miliary mottling is seen. The patient may be quite sick and needs prompt treatment. Bronchiectasis and lung fibrosis are some of the long-term sequelae of pulmonary tuberculosis. Thank you.